Hi, welcome to this latest podcast from the NHS in Staffordshire and Stoke-on-Trent. I'm Richard Caddy.
And I'm Dr Paddy Hannigan.
And we're talking today about all things general practice. Paddy, do you just want to tell us a bit about who you are and what you do?
Yeah, I'm a GP in Stafford. I've been a GP in Stafford for over 30 years now, and I have a role in the integrated care system as the clinical director for primary care. Primary care is not just general practice. It also includes community pharmacy, optometry and dentistry.
Right, so we've just had a pandemic, people are living longer, we've got rising demand, and we've got things like an ageing workforce to contend with. So quite a challenging time to be a GP, I'd imagine.
Yeah, it's a very challenging time at the moment. There's a number of different problems happening at the same time. So the population is getting older quite rapidly, and with that comes health-related problems. At the same time, the GP workforce, the number of GPs in the system, has actually been diminishing for a number of years.
And I think the scary thing is the number that are planning on retiring in the next few years, either because of their age or they're just feeling a bit burned out.
Yes, I mean we hear a lot about that, and again there is a sort of a similar bulge in the GP and the GP nursing workforce, actually is even more pronounced there.
If you look at the media, people will say things like, "I can't get through on the phone, and when I do get through on the phone, I can't get an appointment for weeks." How is that actually reflected?
The media have reduced it to you can't get an appointment with your GP, which is a good headline, but it's both true and not true at the same time. A lot of GP surgeries run on a phone us at 8 o'clock in the morning to book an appointment. So you get this huge bulge of appointments. You get the phone lines are blocked, and no matter how many phone lines you've got going into a GP surgery, you're restricted by the number of staff on the other end of the phones who can answer those phone lines. The statement's not true because actually we're seeing a sort of spectacular number of appointments or patients on an annual or even monthly basis. So in Staffordshire, there's 143 GP practices, and between them they see 5.8 million appointments a year. That's 5 to 6 appointments per head of the population. So that's a lot of activity. So we're doing more than we were doing 2 years ago. Activity levels have gone up about 11% from before COVID.
What is the solution?
There's a strategy, I guess. The government have been trying to widen the GP workforce by recruiting a lot of people into general practice who didn't traditionally work there but now form part of the GP team. So we've got pharmacists working in general practice, we've got physiotherapists, we've got mental health workers, we've got a whole range of different staff. But we've kept it quiet. We haven't really explained this to patients, and everybody still talks about getting an appointment with their GP.
Is that starting to cut through now?
It's broadened the GP workforce, it's increased our capacity. There was some work done a few years ago by the Royal College of GPs which suggested about a quarter of GP appointments, the patients might have had their problems solved better by somebody other than the GP. If we could direct those 25% to the right place first time, nobody would have a problem getting an appointment.
But I think that requires a really big culture change, doesn't it? Because, as you've already said, everybody wants to see their GP, and nobody wants to tell the receptionist what they want to see their GP about.
Our reception staff are trained in this. We spend a lot of time and energy trying to ensure that they know exactly how to direct people to the right place. We need to sort of stop talking about I want to see a GP and start talking about this is my problem, how can I best get it sorted out.
What do you want to be concentrating your time on?
So we have a strategy for general practice in Staffordshire and Stoke-on-Trent. There's three streams of work that come through general practice. There's what we call same-day urgent care, people who have infections, illnesses, or acute medical problems that need to be fixed pretty quickly. There's personalised care, which is often called complex medical care. So it's people who have complex medical problems, often several different medical problems. They're often frail, they're often older, they've often got quite poor health, and also complex mental health problems, people with significant mental illness. That's where our GP workforce needs to concentrate. There's really good evidence that having continuity of care, i.e. seeing the same GP over an extended period of time if you've got complex problems, is much more effective. It actually reduces your chance of being in hospital by about 25% if you get that level of personalised care. The third stream of work is prevention. And prevention is actually a range of things. It starts with prevention, but it actually also encompasses what we call long-term conditions. It's conditions such as diabetes, respiratory illnesses such as asthma and chronic obstructive pulmonary disease, and cardiovascular disease. Those are the big three areas in prevention. And we can start by trying to prevent them, but also we need to manage them the whole way through. The plan is to integrate community teams like the community diabetic nurses, but also with a much wider range of people, so that mental health teams, community teams, social care teams, the people who support people in the community around long-term conditions like dementia, and really using much wider range of assets in the community to support patients. There's a high level of trust between healthcare professionals and patients, and that trust sometimes takes a long time to build and a lot of effort to maintain. But it's quite effective in terms of particularly managing people with complex medical care. There's a tension between having facilities that allow us to house these much larger teams to do much more of work in the community, with the personalised care that we want to try and maintain as one of those four building blocks. And that can be done. A lot of practices still encourage patients who have complex problems to see the same GP each time. But equally, if you've got a same-day urgent problem, if you pick up your child from nursery and they've got a fever and it's 5 o'clock at night and you want somebody to medically assess them,
Any port in the store.
Yeah, you want to see somebody who is a competent practitioner, but you want to see them now, and so it's possible to do both of these things. It's possible to build a same-day urgent care model that uses this much broader workforce, but increases the likelihood of you being able to get an appointment today if you need to be seen.
Another key reform of the last few years is the development of things called primary care networks, which is GP practices grouping together to pool resources. Do you want to tell us about how that's progressing?
Yeah, so we have 143 GP practices in Staffordshire and Stoke-on-Trent. The average practice is around 10,000. We have a few practices that already work together. They're part of single organisations, where there may be 3 or 4 practices who are working together. Nationally, there was a feeling that small scale was what made it difficult for practices to do some of the developments, to employ some of these new roles, and there was a feeling that if we could get practices to work in groups covering about 30 to 50,000 patients, then they could start to pool some of their resources, pool some of their management activities, to be able to employ some of these new roles across the 4 or 5 practices in the grouping. So it's a way of organising practices to allow them to work with this, particularly the new workforce model, but also to start to get some efficiencies around the management of the practices.
So what is primary care going to look like in 10 years' time?
So I'm an optimist. I think we'll come out of this, and I think things will improve, both for the workforce in general practice, but also from the patient's perspective. I think the experience will improve. I think we're not going to go back to a system where all the work is done by GPs. I think we're going to this model of a much wider workforce will continue. I think we'll see that development of the whole community team, the integrated community team, and I hope, particularly with all this digital innovation, that people's experience of contacting the team and sorting out their problem will get steadily easier. There's a big recruitment drive going on. There's a huge number of GPs in training coming through, and it takes 5 years at medical school, a couple of years after medical school, and then 3 years of training beyond that. So it's about 10 years from beginning to end to produce a new GP. So we're beginning to see that. The wider workforce, I think, will stay, but between those two different things, then I think the capacity in general practice will steadily increase. I think the ways that we're working, particularly within the integrated care system and working together, particularly with the hospitals and the community services, is potentially going to be a significant change. And I think this whole thing around prevention and lifestyle is going to kick in, and we'll see much more concentration on trying to keep people healthier for longer. It's almost the most important thing. We always talk about improving life expectancy, but actually what we really need to do is we need to try and improve people's health so they stay fit and healthy and independent for as long as possible.